Hello, everybody. We are live. Welcome, good evening, or good afternoon, depending on where you're joining us from. Tonight, you are going to be viewing our webinar related to the USCLC program focusing on cutaneous B-cell lymphomas. So if you're not familiar, the USCLC stands for the United States Cutaneous Lymphoma Consortium, and their annual workshop on the biology and treatment of cutaneous B-cell lymphomas was actually on June 26th. So our speaker tonight, Dr. John Zick, was one of the presenters at that workshop, and he will be sharing some of the takeaways with us from that meeting. Hi, Dr. Zick, how are you tonight?
I'm doing well. How are you, Hillary?
Wonderful, thank you. Dr. Zick is a professor of dermatology at Vanderbilt University Medical Center. So we are very grateful that you're joining us tonight. Thank you so much. What's going to happen is I'm going to turn things over to Dr. Zick here in just a minute. If at any point during the program you have any questions, you can see the Q&A icon on the bottom of your screen, and you can just click that and type your question in, or you can type it into the chat, and we will address questions at the end as time allows. So I'm going to go ahead and turn things over to Dr. Zick. Thank you so much.
Thank you, Hillary. Yes, it's my pleasure to give our listeners an update to focus on the highlights from the USCLC annual virtual workshop that was held, as Hillary mentioned, on June 26th. And although the focus of the workshop was cutaneous B-cell lymphoma, there were some presentations that were made on cutaneous T-cell lymphoma. So hopefully there'll be a little bit of something for everyone listening. So the outline for this evening's webinar is to start out with some definitions. I'm actually going to, just as a very basic introduction, talk about what a lymphocyte is in relationship to other white blood cells, and then the focus will be an overview of the presentations at our annual workshop. As many of you know who are listening, the primary cutaneous T-cell lymphomas are defined as cancers of the T lymphocyte cell where the skin is the primary organ of involvement. And that helps to separate it from peripheral T-cell lymphomas where the lymph node is the primary organ of involvement. And analogously, the primary cutaneous B-cell lymphomas are cancers of the B lymphocyte cell where the skin is the primary organ of involvement. And although there are a larger percentage of T-cell lymphomas that are primarily involving the skin, there are still quite a few of the B-cell lymphomas that primarily involve the skin. So I've done this before for patient educational sessions, and that is just to kind of give you an overview of what a lymphocyte is and what its role is in the immune system. So this diagram looks like an organizational chart, is meant to show you the major components of blood and the breakdown of white blood cells. And so I'm going to move my cursor here. So blood is primarily composed of red blood cells, white blood cells, and platelets. The platelets are important for clotting. The red blood cells are important for carrying oxygen. And the white blood cells are extremely important for fighting off infections and what we call immune surveillance, which actually includes surveillance of cancer cells that might be developing in our bodies. And the different white blood cells are in this row. Neutrophils are white blood cells primarily involved in fighting off bacterial infections. Eosinophils are primarily involved in fighting off parasitic infections, but eosinophils might be elevated in cutaneous T-cell lymphomas and in other types of allergic reactions. I'll get to the lymphocytes in a second. Monocytes are important immune system cells. Monocytes have an excellent ability to engulf bacteria, dying cells, and other things like that. They're kind of like the Pac-Man of our immune system. And then we have basophils. We're not exactly sure of the primary role of basophils, but they contain these little granules that are often released during allergic reactions. So let's focus on the lymphocytes. You can think of the lymphocytes, they're kind of like the coach or the leaders of the white blood cells in our immune system. In particular, the T lymphocytes. And there are also B lymphocytes and natural killer NK cells. Those sound quite ominous. The natural killer cells are usually the first on the scene of an infection or a wound. They're kind of like the first responders of our immune system. But the T lymphocytes, there are many different kinds, but the two major kinds that you should probably be aware of are called helper T cells and cytotoxic T cells. And when we talk about a T cell, that term is synonymous with T lymphocyte. And for those of you that are listening that have cutaneous T cell lymphoma or have family or friends with cutaneous T cell lymphoma, we're really talking about a malignancy of either the CD8 cytotoxic T cells or the CD4 helper T cells. Now, and so this is really the essence of the T lymphocytes, and a majority of cutaneous lymphomas are cancers of the T lymphocyte cells. So let's change a little bit and talk about the B lymphocytes. So the B lymphocytes have a slightly different function. So the T lymphocytes are kind of like the coach or the coaches of the immune system, and they tell the B lymphocytes and NK cells and other cells kind of what to do. The T lymphocytes themselves can attack bacteria and cancer cells. The B lymphocytes really don't have that ability to attack other cells. There are two major types. There's the memory B lymphocytes and the plasma cells. And so together, the memory B lymphocytes and the plasma cells make up our B lymphocyte population. What's interesting is that the memory B lymphocytes develop either early on in our development as a fetus and as an infant, but can also develop in response to an infection. And they circulate in our immune system until triggered by that specific infection. And then the memory B lymphocytes transform into plasma cells. And the plasma cells are little factories. And it's the plasma cells, a type of B lymphocyte, that make and release antibodies. So for those of you that have been vaccinated against the COVID-19 virus, that immunization was meant to do two things. It probably stimulated a T lymphocyte response that then stimulated a B lymphocyte response that created plasma cells to make and release antibodies to fight off COVID-19. And so that's kind of how the B and the T lymphocytes interact with each other. All right, now with that introduction behind us, let's go ahead and see some highlights from our workshop. As was mentioned, the workshop that was held on Saturday, June 26th, started at 10 a.m. Eastern Time and ended at 3:30 Eastern Time. And I was telling Hillary that my golden doodle, Dolly, was at my feet for most of the conference, which was really interesting. She must have really been intrigued by the cutaneous B-cell lymphomas. So this was our agenda. And so you could see some of the topics and perhaps some of the speakers that talked. You might even recognize them. Perhaps some of these speakers are your doctor. And we started with an introduction of primary cutaneous lymphoma by Elise Olson. And this wasn't only focused on the cutaneous B-cell lymphomas, but also the cutaneous T-cell lymphomas. And then we went into a discussion of both low-grade B-cell lymphomas. By low-grade, we mean very slow-growing and usually good prognosis, as opposed to the high-grade B-cell lymphomas that are fast-growing and often have a worse prognosis. We went into a discussion about pseudolymphomas, and we'll talk about that. And then for part two, on the right, we really did kind of a deep dive into some biochemistry and molecular biology of the B-cell lymphomas. We had a great talk that I'll mention about Epstein-Barr virus and its role in some of the B-cell lymphomas and what we call LPDs, lymphoproliferative diseases. And then we had a very nice talk by Dr. Battistella from Paris about systemic B-cell lymphomas. So as you might imagine, some people that have B-cell lymphoma that involves a lymph node, we know that unfortunately for some of those patients, the B-cell lymphoma could spread beyond the lymph nodes to other organs, including the skin. So dermatologists and hematologists need information about how do we separate those B-cell lymphomas that started in the skin and those that started in the lymph node and spread to the skin. So let's get started. First, let me summarize Elise Olson's talk about primary cutaneous lymphoma and the international collaborative recommendations for clinical trial design, assessment, response criteria, endpoints, and update to staging. As you may know, Elise Olson is an internationally recognized expert on cutaneous lymphoma, and she's also an excellent leader. And Elise Olson single-handedly brought together cutaneous lymphoma experts from around the world who came together to collaborate in order to standardize the way that we study new medications in clinical trials for patients with cutaneous lymphoma. This was a very important endeavor. This was done approximately 7 years ago, and it was time to update the recommendations for trial design and assessment and the other things listed there. And so some of the questions that this significant collaborative paper was meant to answer included, how should we assess whether a patient has responded to a study medication? And because cutaneous lymphomas always involve the skin, but can sometimes involve lymph nodes and blood, this is a little bit more complicated question than you can imagine. However, in terms of skin involvement, what the group came to as a consensus that we need to continue to look at the change in the percent body surface area involved with the cutaneous lymphoma. And this includes both the cutaneous T-cell lymphomas and the cutaneous B-cell lymphomas. Another question that we were trying to answer in this paper was how much clearing of the skin is necessary for patients to be labeled as responders. And in the general consensus, not only among this group, but within oncology, is that most oncologists and dermatologists, hematologists, have 50% clearing of the cancer as usually the measurement necessary to label a patient as responding to that study medication. So we kept that, but we have to figure out, how do you assess 50% clearing? You could look, if the patient starts with 50% of their skin involved with a cutaneous lymphoma, and after being on the study drug for 6 months, now they have 10%. Well, that's clearly more improvement than 50%. So that particular patient would be labeled as a responder. Another question that we tried to assess was how many abnormal T cells are necessary to be labeled as a significant involvement. And so when you are assessing the number of malignant or abnormal T cells in the blood, the criterion that we came up with was greater than 1,000. So if you have more than 1,000 abnormal T cells in the blood, that's when you can be labeled as having significant involvement. And finally, and the best news, is that this collaborative paper has been submitted to the medical journal Blood. And we've already had some feedback from reviewers who overall were pleased with the content of the paper. So hopefully this will be published within the next 6 months. And it can be used by both physicians who are anticipating starting a clinical trial for cutaneous lymphoma, but also pharmaceutical industry and researchers who may be developing a new medication to be used to treat cutaneous lymphoma. They can use this paper to assist them in designing the clinical trial, figuring out how are we going to assess how a patient's responded and what endpoints. So the endpoint might be just overall survival. The endpoint could be complete clinical response. The endpoint for some patients might be improvement of itching. So there are many different endpoints that we use in clinical trials so that we can label the trial as a success or not. So that's a brief summary of Elise Olson's excellent presentation on a collaborative paper that we hope to see published over the next 6 months. So now let's move into the world of cutaneous B-cell lymphomas. And even if you have, or your family members have cutaneous T-cell lymphoma, I think there are some lessons learned from studying the cutaneous B-cell lymphomas. The first talk was by Dr. Mishi Shinohara, who is the co-director of the Cutaneous Lymphoma Clinic at the Seattle Cancer Care Alliance, which is at the University of Washington School of Medicine in Seattle, Washington. And Dr. Shinohara gave an excellent presentation about primary cutaneous marginal zone lymphoma and follicle center cell lymphoma, the so-called low-grade or slow-growing lymphomas. And for those of you that haven't seen the list, it's actually fairly small compared to the list of the types of cutaneous T-cell lymphomas. And this abbreviation up here is primary cutaneous B-cell lymphoma. And the WHO EORTC stands for the World Health Organization, European Organization for the Research and Treatment of Cancer. And these two organizations have been collaborating so that there's a unified world classification for cancers. And this is their classification for the primary cutaneous B-cell lymphomas. And the two that are in green, the primary cutaneous follicle center lymphoma and marginal zone B-cell lymphoma, are considered the low-grade, indolent, slow-growing subtypes that have an excellent prognosis. And one topic that Dr. Shinohara touched on, which is important, is how do we work up a new patient? Usually these patients will present with a nodule or a papule that might be on the head and neck, chest, back, lower. They could be actually anywhere on the skin. And a biopsy is done by a dermatologist, and oftentimes the dermatologist is not suspecting a cutaneous B-cell lymphoma. More often than not, they're expecting another cancer such as basal cell carcinoma, squamous cell carcinoma, sometimes even a melanoma. And then the diagnosis comes back. There are lots of B cells in the pathology specimen. And after usually a lot of work and a lot of special stains, the pathologist will come up with a diagnosis of a B-cell lymphoma. But because B-cell lymphomas usually start in the lymph nodes and spread to the skin rather than start in the skin, it's really important to do imaging. So obviously you're going to do a skin biopsy and you'll get some labs, routine labs for anyone with a lymphoma, a complete blood cell count and lactase dehydrogenase, which is just an enzyme that can be released by lymphoma cells. But I would almost put this in the definitely do category, but you need some type of x-rays or imaging. And for most people, that's a CT scan of the chest, abdomen, and pelvis, or what's called a PET scan with a CT scan. So the PET CT scan is a little bit more sensitive than the CT scan alone, but either can assess about whether or not there is an increase in the size of lymph nodes. SPEP stands for serum protein electrophoresis. HEP is a hepatitis panel, HIV, the AIDS virus, and pregnancy tests for women of childbearing potential. You might do a skin biopsy for flow cytometry, which is a special test that we can do on biopsy. You may be, your hematologist or oncologist may want to do a bone marrow biopsy, and you may want to do a special test on blood called flow cytometry, which is meant to assess whether or not there are any abnormal B cells circulating in the peripheral blood. What I do at Vanderbilt, I do a skin biopsy, labs, I do imaging, usually one of these two. I don't always do an SPEP unless some routine labs might show an abnormality. And I think in certain settings, these tests are very important. My patients do not do bone marrow biopsies. And so the take-home message from Dr. Shinohara was that these two cutaneous B-cell lymphomas, the follicle center lymphoma and MZ, the marginal zone lymphoma, are indolent, which means slow growing for the most part. Oh, except for the follicle center on the leg. There's something about the leg and the cutaneous B-cell lymphomas that makes it a little bit more aggressive. And we're going to talk about a special type of cutaneous B-cell lymphoma on the leg. But the follicle center lymphoma that may look pretty indolent and slow growing and not too aggressive under the microscope, if it's on the leg, those patients need to be treated probably a little bit more aggressively, or perhaps at least, the very least, watched more closely. And so that was something I took away from the conference, is that when you have a cutaneous B-cell lymphoma on the leg, especially this, and really only this follicle center cell type. If you have a marginal zone lymphoma on the leg, it's fine. Those patients are going to do great. But if it's a follicle center cell lymphoma on the leg, patients should be watched a little bit more closely. I agree with Dr. Shinohara's conclusion that bone marrow biopsy is not necessary for most patients. The doctors who are listening learned that there's two different types of marginal zone lymphoma, and some dermatologists and hematologists were actually relying quite a bit on this particular test called BCL2. And if it was positive, we were very worried about it being a systemic or node-based follicle lymphoma. And if it was negative, we were much less worried. But what Dr. Shinohara showed us is that there are patients where this particular test may be negative, but patients may also have a systemic lymphoma. So that just means that we should definitely get some imaging studies. And finally, and this is the best news of all, is that most patients respond very, very well, regardless of treatment. We talked a little bit about treatment. It can be radiation for some patients who have multiple papules and nodules and growths on the skin. There are some intravenous treatments that we can do, but most patients don't need that. So that was kind of a nice summary of Dr. Shinohara's. Let's move on and talk about Dr. Gru's talk, which was about the high grade or perhaps the more worrisome of the cutaneous B-cell lymphomas. And Dr. Gru, who is from the University of Virginia, Dr. Gru is a skin pathologist and a lymphoma pathologist. So he has a lot of experience looking under the microscope at both cutaneous and non-cutaneous lymphomas. And probably the most common type of high-grade cutaneous B-cell lymphomas is this one here, called primary cutaneous diffuse large B-cell lymphoma, leg type. It might seem very unusual that we have a type of cutaneous B-cell lymphoma with an anatomic location that's part of its official name. But it turns out that probably over 80% of this type of lymphoma of the skin is localized to the leg. It does mean that 20% aren't. And again, there is something about the leg that seems to indicate a slightly more aggressive type of cutaneous B-cell lymphoma. And this is a slide from Dr. Gru's presentation, and it shows that this particular patient had a nodule on the skin with a little ulceration on it, and it was firm and probably tender. And a biopsy was done and led to this diagnosis of what we call primary cutaneous diffuse large B-cell lymphoma, leg type. It's usually seen in elderly people, usually mean age of 77. Women are affected slightly more than men. And of all the cutaneous B-cell lymphomas, it only is about 10 to 15%. We really don't know what causes this particular lymphoma, as we do for almost 98% of all cutaneous lymphomas, unfortunately. But this can be an aggressive lymphoma. So the cancer networks have usually recommended systemic treatment with a medication called rituximab, plus a common chemotherapy regimen called CHOP. Dr. Grew also talked about a few other rare lymphomas. He talked again, as Dr. Shinohara did, about the follicle center lymphoma that is on the leg. And that's why this bullet point says location, 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 like realtors mentioned. We talked briefly about intravascular large B-cell lymphoma, and then lymphomas with plasmablastic appearance. And those are terms, obviously, we don't expect patients to understand, but it just helps you understand the complexity of the B-cell lymphomas and how it's very important that your biopsy, if you're ever diagnosed with one of the large B-cell lymphomas or high-grade B-cell lymphomas, how important it is to make sure that that pathology, your pathology slides, get in the hands of an excellent pathologist with experience reading it. Just a few words about intravascular lymphoma. It's a very unusual and rare type of lymphoma. And normally the cancer cells, the B lymphocyte cells that become cancerous, are in the second and third layer of the skin, the dermis and subcutaneous or fatty layer of the skin. In this particular type of lymphoma, the B-cell lymphoma cells are within the blood vessels, some of the medium and larger blood vessels, and so it can easily be missed. These patients usually present with a variety of presentations. They can have a nodule that's under the skin. They can have plaques. They can have kind of a reticular or lacy pattern of erythema. I've seen probably 2 patients with this in my career, and both patients had tender areas. So these are usually tender. And that would definitely give a dermatologist a clue that it should be biopsied. And so we're learning more about this, and hopefully we'll be able to make the diagnosis sooner so that we can treat patients effectively. So thanks to Dr. Grew for teaching us about the diffuse large B-cell lymphomas. Next up was Johan Gietart. Johan Gietart, both a professional and personal friend of mine, is a professor of pathology and dermatology at Northwestern University School of Medicine. And Dr. Gietart talked about a very interesting topic, and that is a pseudolymphoma. And the word pseudolymphoma is a very confusing term for both physicians and patients. The word pseudo means false, and so false lymphoma. And what this means is that under the microscope, a pathologist may look at it and be very worried that the patient has a lymphoma. But when you do more testing and you follow the patient over time, what you find is that the patient actually does really, really well. And so it might look worrisome under the microscope, but the patients do well. However, it creates a dilemma for pathologists. And Johan Gietart, as he was in the middle of his presentation here, was talking about how it's such a gray zone. And some pathologists are very hesitant to make this diagnosis, and others feel that it's more confident. And it's very important. And I think that Dr. Gietart mentioned this, that we need a combination, we need 2 or more brains coming together. The clinician that saw the patient, heard the history, examined the patient, and then we need the pathologist. And the pathologist and the clinician need to be talking to each other to see whether or not we should fall on the side of the fence that this is not a cancer, but rather looks like one, and therefore we'll call it a pseudolymphoma, or should you be over the fence and it's best that we call this a lymphoma cancer. And one of the diseases or entities that Dr. Gietart spent a great deal of time discussing is something called cutaneous lymphoid hyperplasia. So cutaneous means skin, lymphoid means lymphocyte cell, and hyperplasia just means that there are many, many of a particular cell. The word hyperplasia does not mean cancer though. So if you see the word cutaneous lymphoid hyperplasia or maybe a gastric mucosal hyperplasia. It just means that the tissue, the cells in that particular tissue, there's an increased number of them. And so Dr. Guittard was discussing whether or not this disease, this skin disease or skin label of cutaneous lymphoid hyperplasia, is it a reactive process? In other words, meaning did something happen at that spot in the skin to trigger this nodule to form? Or is it something that just forms without any possibility? And what Dr. Guittard did in this slide is he actually broke it down by a cutaneous lymphoid hyperplasia where we see mostly T cells versus those that we see B cells. And what he did, I thought, was just very enlightening to me. And that is, he listed some of the triggers that have been reported in the literature, from herpes virus infection to molluscum, to certain drugs, bug bites. Bug bites are huge. You can see bug bites both for T cell and B cell. So if you or your family members ever get bitten by a bug, oftentimes ticks and chiggers that we see here in the Southeast can cause persistent bug bite reactions. And sometimes the immune cells in the skin, a little switch is tricked somehow. And then they form a nodule that just sits there and sits there and sits there months and months and months after the arthropod bite. And there's many reports of bug bites or arthropod bites triggering this cutaneous lymphoid hyperplasia that under the microscope may mimic a cutaneous T cell or a cutaneous B cell lymphoma. And there are others that are listed here. By the way, if any of you are listening in or reviewing this webinar from Europe, it is interesting to note that in Europe, as opposed to the United States and North America, Borrelia is a not uncommon trigger. A Borrelia, a tick bite, where the tick transfers this bacteria, Borrelia afzelii, into the skin. Apparently, when the immune system reacts to Borrelia, it can sometimes cause this cutaneous lymphoid hyperplasia. And Dr. Guittard went on to help us understand and understand the relationship between cutaneous lymphoid hyperplasia and the two indolent type of cutaneous B cell lymphomas, follicular cell lymphoma and marginal zone lymphoma. And Dr. Guittard has published at least 1 or 2 papers suggesting that patients that might start out with what's called cutaneous lymphoid hyperplasia may at some point later in their disease have a biopsy done of a papule or nodule that under the microscope now seems to fit criteria for a marginal zone lymphoma. We usually don't see the cutaneous lymphoid hyperplasia moving towards follicular lymphoma. This is more for the physicians than it is for patients, but it just is helpful to know that there are tests that can be done to help us distinguish between these 3 entities, and that's what this slide was doing. So Dr. Guittard ended his presentation saying that distinguishing from the low-grade lymphomas, such as the marginal zone and follicle lymphoma, and cutaneous lymphoid hyperplasia may be difficult. And so don't be too frustrated if the physician taking care of you is frustrated as the pathologists go back and forth between these diagnoses. Dr. Guittard also mentioned that perhaps the marginal zone lymphoma shouldn't be regarded as a lymphoma cancer, but rather as something we call a lymphoproliferative disease. And the lymphoproliferative diseases are not considered cancerous. It's just almost like a hyperplasia, like we mentioned, of the lymphocytes in the skin. And then there are these external triggers that might cause the marginal zone lymphomas along with the cutaneous lymphoid hyperplasias that we mentioned. So that was Dr. Guittard's presentation. which was very entertaining. We're going to take a little sidebar as we did during our workshop, and I'm going to show you a little bit of some research-based presentations. Now, these often have nothing to do with cutaneous B-cell lymphoma, but for the first time, the USCLC invited researchers from around the country and the world to submit abstracts. And what you're going to see are some highlights from the 6 or so abstracts that were selected for oral presentation. And let me show you some of those. So in this particular presentation by Yumeng Zhang, who is from the Department of Medicine and the Department of Cutaneous Oncology at Moffitt Cancer Center in the University of South Florida. In this particular study, they looked at the type of bacteria that are on the skin of patients with mycosis fungoides. And they looked at whether or not the type of bacteria that are on top of the skin overlying a patch or plaque of mycosis fungoides, which is a type of cutaneous T-cell lymphoma, versus normal skin might be different. They also, I thought it was very clever, they also looked to see if patches of mycosis fungoides that were itching had different bacteria on top of them than other patches. And so let's see what some of the results were. And this kind of just jumps to the summary. And so what they found was that thick lesions of mycosis fungoides had less of a bacteria called Propionobacterium and less of a bacteria called Bradyrhizobium and more of a bacteria called Paracoccus. And if it was kind of a red patch, they saw more Staphylococcus. That might be a bacteria that you're familiar with, Haemophilus, and a few others. And then they looked at, what about itchy patches? Were there certain bacteria that we saw more often in itchy patches? And there were two. There was one called Sphingomona and another called Parvomona. And then in painful patches or plaques of skin, they saw kind of a different collection. Now, I think they had somewhere between 12 and 25 patients. I don't recall the exact number, but most listeners thought this was very interesting to think that there may be differences in bacteria depending on the type of skin lesion in patients with mycosis fungoides. So the question is it the bacteria that came first or the skin lesion? So in other words, was it the thick plaque that attracted this kind of bacteria, or was the bacteria there that triggered the skin to develop into a thick plaque? Kind of the chicken or the egg. We don't know, but hopefully there will be more studies looking at the types of bacteria on a patient's skin. And so the conclusion from this particular study by Zhang and others from the Moffitt Cancer Center is that they identified what they are calling microbial signatures. And that's because they were looking at DNA. And as I just mentioned, they said that perhaps different microbes or bacteria might be associated with different changing diseases in patients with mycosis fungoides. And as I just mentioned, I think there need to be larger studies of patients with MF. And then, of course, that begs the question, if we target patients with mycosis fungoides with specific antibiotics to perhaps knock out certain bacteria, will that improve pruritus, pain, maybe help shrink plaques, or even help with the redness? I think most of you listening who have cutaneous T-cell lymphoma may have had antibiotics at some point in your course. And it's fascinating. I've certainly seen it in my patients where decreasing the amount of bacteria on the skin often improves itching, redness, and sometimes the patches themselves. In this particular study by Tony Zhang, at the University of Pittsburgh Cutaneous Lymphoma program. They were looking at T cells in Sézary syndrome. Sézary syndrome is a type of cutaneous T cell lymphoma where patients have redness all over their skin and significant blood involvement. Their approach was to collect samples of blood from 18 patients with Sézary syndrome, isolate what they call the peripheral blood mononuclear cells, which is basically the white blood cells, and then do really sophisticated genetic analysis on those blood cells. And what they found is that it appears that early on in the cutaneous T cell lymphoma evolution, we have mostly normal healthy cells, but there probably are very few cells. As a matter of fact, we believe that all malignancies start with a founder cell. That is the very first cell to start to divide a little bit out of control. What this group proposes is that there might be multiple populations of tumor cells throughout the illness of a particular patient, and that it might start out with a particular type of T helper cell called Th1, and then it might move to what we call chronically active S2, and ultimately to Th2, which is usually what we see normally when we do peripheral blood testing. But they suggested that there might be this intermediary cell. And perhaps if we learn more about this intermediary cell, we can target it to shut down the disease earlier and faster. Ellen Kim from the University of Pennsylvania gave an excellent talk summarizing a multi-center trial using a liquid applied to the skin overnight and then shining a light on the particular spot that was treated with a liquid, and using to see in this clinical trial to see if that might help resolve skin lesions of patients with early mycosis fungoides. And the medication is called hypericin. And it turns out that this ointment, I may have mentioned a liquid, but it's actually a greasy ointment, is a synthetic formulation of this particular drug called hypericin. And what's really interesting is that this particular medication is absorbed primarily by malignant T cells rather than normal T cells, or rather than T cells that are just sitting in the skin not doing much, as opposed to B cells and skin cells and things like that. Therefore, the idea behind using this medication is that it can kind of be used to selectively treat individual lesions. So let's say you have mycosis fungoides and you have a persistent patch on your right upper medial thigh because the narrowband UVB phototherapy can't reach it. Well, this could be a potential treatment for you, where you would apply this ointment overnight. Then the next day you would go into the dermatologist's office where they would shine a visible yellow light. And we're not talking about a laser or anything fancy, just a visible yellow light. And it turns out that this drug hypericin absorbs visible yellow light, and it kind of excites the molecule. And because it's within a cancer cell, as the hypericin medicine is excited, it releases all these toxins in the cell that can lead to the death of the cell. So this particular study enrolled 118 subjects in the treatment arm, and you could say fewer in the placebo arm. And ultimately, patients were followed for at least 6 months. And the conclusions of this particular study was that 16% of the lesions responded at 8 weeks, 40% at 16 weeks, and up to 50% at 24 weeks. And the responses were seen in both flat patches and thicker plaques. And the safety profile was pretty good. It does cause some irritation of the skin. Some of you may have had a similar treatment called photodynamic therapy for the treatment of precancerous skin lesions called actinic keratoses. So this is a modification of what's called photodynamic therapy for the treatment of early stage mycosis fungoides. And so you can look forward to the publication of these results. The next study that was presented in the research section of abstracts was a study looking at the CD4 T cell population using a special technique called single cell RNA sequencing. And this came from Yale, and it was presented by Jingjing Ren. And what the summary was of their study using this special technique was that the cutaneous T cell lymphomas, as you know, there are many different types. Not only do they look different clinically, but when we use this special technique to look at what's called mRNA, we can see that although a majority are a special type of helper cell called T helper 2 cell, we also have some that have T regulatory cells, T follicular cells, Th17 helper cells. I didn't really introduce you to these types of T cells, but they are indeed important types. And this study, you'll recall, along with the other previous study that I mentioned, also found that there's probably some intermediate cell between the founder cell and the ultimate cancerous cell that we look for in the blood and the skin. And perhaps we can target those intermediate level cells. So I found that pretty interesting. And then this particular study, this is a different study, was presented by Ashley Craddock. And Ashley is at the University of Virginia in Charlottesville. And Ashley introduced me to this special test that pathologists can do called ultrasensitive RNA scope in situ hybridization. And what I found interesting about this particular method that can be done on a skin biopsy is that it might help us skip more expensive types of testing. And just so you know, when B cells become cancerous, they usually produce one of two types of light chains. And the types of light chains on the surface of the cell is usually either kappa or lambda. Now, traditionally, using in situ hybridization, that's ISH, and normal stains, you see that for kappa in this particular specimen, you could see some kappa staining and some lambda staining, and it's kind of hard to see. I think the pathologist wouldn't be able to make quite a difference saying, oh yes, there's definitely more kappa than lambda. Well, with the RNA scope type staining using this special technique, it makes it much easier for the pathologist to say, oh yeah, there's more kappa staining than lambda. And I think you would both agree there's more brown dots on the left slide than the right slide. And so big deal. Well, it can be a big deal to the patient. That's you all. And it could be the difference in several $100s because normally what you would have to do if you didn't have that sharp distinction, knowing that there's a clonal population or there isn't, you would have to get what's called immunoglobulin heavy chain gene rearrangement. And that could be thousands of dollars. And so ultimately, we can save hundreds of dollars for patients by doing this special test. So I thought that was pretty interesting. And so this slide just goes on to say that in addition to reduced costs, there's less reliance on molecular testing, which may improve turnaround times. That's a good point. When we do gene rearrangement testing, it can definitely lead to a week or sometimes a week and a half of delay in getting to the diagnosis. So this test is quicker, leading to giving the pathologist more information so that they can make a better diagnosis. And then we're going to switch gears quite a bit here. This was a study presented by Dr. Tarshin Sethi, who is at Yale University School of Medicine in the Department of Medicine and Hematology. And Dr. Sethi presented the results of a small group of patients at that institution that were treated with a combination chemotherapy regimen called EPOCH. And each letter stands for a different chemotherapy drug. They make the point that most patients that have more advanced cutaneous T-cell lymphoma, such as mycosis fungoides, are usually managed with one medication given intravenously. Those medications may include drugs like romidepsin, mogamulizumab, brentuximab, and others. and that patients who have what's called large cell transformation, so in patients with mycosis fungoides, the cancerous T lymphocyte cell is usually small, and there are a lot of them, but they're usually small. At some point in some patients, the cancer cell can transform from a small cell to a much larger cell. And that usually means that the prognosis goes down. And so those patients who have large cell transformation and aren't doing as well are often candidates for what's called bone marrow transplant. And so what we need to do before we can do a bone marrow or a stem cell transplant on these patients, we basically give them a new immune system from someone else, is we need to knock out all the cancer cells. We truly do not want to have any cancer cells left in the patient. So we need sometimes a more aggressive treatment strategy. And the authors of this particular presentation are saying that perhaps this combination of these chemotherapy drugs down here, etoposide, prednisone, vincristine, cyclophosphamide, and doxorubicin, this may be something to consider. And so they looked at all adult patients that were treated with this chemotherapy from May 2015 to October 2020. There were 11 patients with cutaneous T-cell lymphoma. 10 had mycosis fungoides, 1 with Sézary syndrome, and 1 with something called gamma delta T-cell lymphoma. And what they found was that there was an overall response of 81%. Remember how I defined that as greater than 50% clearing from Dr. Olson's talk? And so that's what that means. Overall response rate, 81% responded. And 36% had a CR or complete response, and median follow-up was 17 months. What these graphs are showing you is that, okay, if patients responded, how long did they stay responding? And that's what we mean by progression-free survival. And you could see that probably by about 8 months, about 50% of patients had relapsed. But that may not mean that they had as much disease on their skin as they did when they started. It just means that they had started to develop some new skin lesions. And then it also shows overall survival. And these patients were really sick. So it doesn't surprise me that, about maybe a third of patients did not survive past 15 months, but you can see that a large number did after that. So that's kind of impressive for patients as sick as these patients were. And so in summary, these authors declared, I think rightly so, that EPOCH is an effective option for aggressive and transformed cutaneous T-cell lymphoma. And for hematologists, they considered it safe. However, these patients are at risk for developing a unique type of lymphoma called pneumocystis pneumonia and herpes virus infections. And so they need to be on medication to prevent these. That's what we mean by prophylaxis. And now we're going to go pretty quickly through the second half here. And so advances in molecular aspects of cutaneous B-cell lymphoma. One of the hard things, I'm sorry, I should introduce the author, was Dr. Choi. And Dr. Choi is at Northwestern School of Medicine. And Dr. Choi was trying to help physicians decide or help us develop a prognostic indicator. In other words, which patients are likely to have systemic spread from their cutaneous B-cell lymphoma, that is spread to lymph nodes rather than not. And what he and others have found is that if we can do special genetic analysis and find mutations in those genes, those patients are probably more likely to have systemic spread of their cutaneous B-cell lymphoma. And then we had mentioned briefly about BCL2 gene rearrangement. If that is present, they're more likely to have systemic spread. And then if they have something called a low proliferation index. So this is information that the pathologist should be using and clinicians in determining whether or not a patient with a cutaneous B-cell lymphoma is likely to have spread beyond the skin. And so I thought this was probably the most useful thing. And this is just a summary of Dr. Choi's talk. And then there was a very interesting talk by Miguel Pérez, who is Associate Chief of Pathology at the Fundación Jiménez Díaz in Madrid, Spain. And Dr. Pérez is an expert on the impact of a virus called Epstein-Barr virus on B-cell lymphomas. And he talked about classifying and the role of this Epstein-Barr virus in B-cell lymphomas. And I thought this was interesting. It's basically showing that if you have what's called a diffuse large B-cell lymphoma and you express something called CD30 on the surface, you live longer than if you don't have it. However, if we look at patients who have this CD30 expression, those that have Epstein-Barr virus also detected in the skin sample or lymph node sample do worse than those that don't. So it seems like if you have Epstein-Barr virus, you're going to have more of an issue in this diffuse B-cell lymphoma. And he just goes on to say that Epstein-Barr virus causes this protein to be expressed on the surface of cells, CD20 or 30 rather. And this was just his summary that EBV, Epstein-Barr virus, plays an important role in lymphoma classification. And it's a box of surprises is what he said there. And then finally, I'm going to talk very briefly about Maxime Battistella, who's professor of pathology at Hôpital Saint-Louis in Paris, France. And he talked about systemic B-cell lymphomas with skin involvement. And he said it's important to recognize secondary lymphomas. These are lymphomas that start in the lymph node and spread to the skin. And these were his take-home messages about avoiding pitfalls and things like that. So I wanted to certainly stop. We have some time left for questions. And I'm going to go into the chat here. Oh, that's Hillary telling me I have a 5-minute heads up here. But I'd be more than happy to answer any questions if anyone has any.
Yes, I'm looking, Dr. Zick, and it looks like we actually don't have any questions. So you must have answered everybody's questions so well. I know it's a lot of information to take in. So I did want to mention to folks, you know, if you need to go back at any point and watch any of this, it will be posted on our website within about a week. So if you think of a question, feel free to send it to us and we'll make sure it gets to the right place so that you can get the answers that you need.
Yeah, and I would just say that it's very uncommon for a patient with cutaneous T-cell lymphoma to develop a cutaneous B-cell lymphoma. And it's very uncommon for a patient with cutaneous B-cell lymphoma to develop a cutaneous T-cell lymphoma. Listening and you have one of the two, you don't need to worry very much at all about developing the other. But I will say that most of the cutaneous B-cell lymphomas are a surprise to the dermatologist that did the biopsy. It's good to know that there are a lot of people doing research on both the cutaneous B-cell lymphomas and the cutaneous T-cell lymphomas so that we can provide the right care to the right patient at the right time.
Great, that's good to know. Thank you so much. And someone's just commenting, thank you, very informative and much to consider and learn. Yes, and thank you so much, Dr. Zick. It was super informative and just encouraging to hear about the new studies and research being done. And I know it's a lot to absorb. Like I said, if you need to watch it again, it'll be on our website within about a week. So Dr. Zick, we are so grateful for your time and expertise as always. And you just have a way of presenting things in a way that's easy to understand. So thank you. And maybe next time we can hear from Dolly too, because I'm sure that everybody would enjoy that. Before we sign off, I would like to thank our corporate partners and individual donors. Without you, these programs certainly wouldn't be possible. So thank you so much, Dr. Zick. We hope you have a wonderful rest of your day, and thanks for giving your time and expertise to us tonight.
All right, my pleasure. Have a wonderful evening.
You too. You can go ahead and sign off, and I'm going to just launch a quick survey here for folks if you're viewing it on your screen, and let us know what you thought of the program. Thank you, Dr. Zick. So let's see, I'm just going to give this a minute to run. If you wouldn't mind participating, it really helps us to improve our programs and make sure that they are the best they can be for you. So we hope you enjoyed it. We hope to see you at a program in the future. Next month, we're going to be hosting our very first Facebook Live, and it's going to be focused on the caregiver's perspective. So, a story of hope for everybody to hopefully tune in and hear about. And we're going to be hopefully doing those quarterly and giving everybody a chance to hear more from other patients, other friends, family of folks living with this disease, and really just get a chance to see some more folks in the community and hear from them. So, with that, we're going to sign off for the night. I hope everybody has a wonderful rest of your day. Thanks so much for joining and hope to see you at another program soon. Bye.